Morning, everybody. Dr. Gillard here. Let's do some CVPP lab. It's week 4, spring 2020. Kind of the star of the show today is deep vein thrombosis. So in order to understand this one test in particular, the modified Perthes test, we have to remember how the blood gets out of the deep system. Here's the skin. The dermis, epidermis is not drawn, but we have a lot of blood up there, and blood of the muscles and everything else, but most of the blood is coming from the dermis and epidermis. But the way the blood drains, as we said in lecture, it goes through the skin, through the dermis via the reticular system, into the superficial compartment. Some familiar members of the superficial compartment were the greater saphenous and lesser saphenous veins and their accessory veins and tributaries. Right. So that is going to be, 15% of that is actually going to leave the lower extremity through that superficial compartment or through that superficial system. But 85% of it is transferred into the deep compartment, or the deep system, and it's transferred through perforator veins, and those veins also have valves, by the way, Woodway valves. They don't let blood come out of the deep system, they let blood go into the deep system. Once in the deep system, most of these veins are familiar, like the peroneal vein, the anterior and posterior tibial veins, the popliteal vein. As we move up, they get bigger. We have the deep femoral vein. We have the femoral vein. Remember, the deep femoral and the femoral vein are members of the deep system. Deep is for dangerous, a dangerous place to get a blood clot or thrombus formation. All right. And remember, that should never be called the superficial femoral vein. It's always just the femoral vein by itself, because I told you that story, superficial femoral vein, they used to call it that a long time ago, and docs were getting their ultrasound reports back, and they were seeing blood clot in the superficial femoral vein, and they were thinking, oh, I remember from medical school, that's not a serious problem. And it's not a serious problem if you get a blood clot or thrombus formation in the superficial system, because most of it, the current flow is into the deep system, and that thrombus gets stuck, or an embolus gets stuck going through the perforators, and it doesn't. I mean, it can swell these things up like crazy. It can swell up your leg, but it's not going to kill you, because it's not going to get out of the lower extremity that way in most cases. But they were confusing superficial and thinking, oh, that's not a dangerous, and they weren't prescribing heparin or sending them to the hospital, and people were dying because of that. So that's really a bad name for that femoral vein. Common femoral vein breaks into the deep and femoral vein, as we'll see. All right, and then you notice how a lot of these veins are embedded, soleus in particular has a honeycomb of blood vessels within it which aren't drawn, but every time you move or sway, if you're standing or walking, it pumps the blood out of your lower extremities. Okay, so and we're going to use this pumping mechanism. I might as well tell you why we got this right here. What if I let me see, can I draw on this? I think I can draw. I forgot to turn my drawing tools, of course. But let's see, that's the laser pointer. What else we got here? Let's do the highlighter. Okay, what if we get Beaver Dam right here? What's going to happen? And this is really the modified Perthes test. Well, the blood from down below can't get out of this anymore. And so the pressure is going to build up, and the blood's actually going to start going back. It's going to backwash into the system here and try to escape this way. Okay, because it's got to get out of the leg. You got more arterial blood coming in to the leg. So more and more's got to get out. So it's backwashing into here. We're going to put a tourniquet around the upper thigh, and we're going to pinch all these vessels off, including this one off. And so where's the blood going to go then? It's not going to go anywhere. It's going to increase until your leg hurts, and that's a positive modified Perthes test. Okay, so that's kind of where we're going with this. Right? Let's see. Go back to my laser pointer. I guess I can just proceed. All right. So on the way out of the system, there's a confluence right here. That's called, or a junction, which is a confluence, is a meeting of different blood vessels. And the players here, we have the common femoral vein right here. This, of course, is once it goes under the inguinal ligament, it'll turn into the external iliac, and then that feeds into the common iliac and then into the inferior vena cava. That's the way out. But we have a confluence here. So here's the greater saphenous. 15% of the blood comes this way. Here's the femoral vein. There's the deep femoral vein. See how they all meet right here? That's called the SFJ, the saphenofemoral junction. That's got, you want to get varicose veins? You knock a couple of the valves in here. There's 2 gigantic valves, sometimes 3, sometimes 1. But it stops blood from accumulating here. You start knocking a few of these veins, and we'll talk about this in class. You start knocking out some of the valves here, especially in this more superficial tissue, and these veins will swell and become damaged, and that's what varicose veins is. But that's the SFJ. It's located about 2 finger breadths, or the width of your tips of your 2 fingers away from the pubic tubercle and down. It's more medial than the femoral. Remember, the femoral nerve was about the midway point of the inguinal ligament. So if you go just a little medial to that, probably about 3 fingers, and then down 2 fingers, you'll run into it. So we want to, when we put our tourniquet on, ideally we could put our tourniquet on here, but our tourniquet will go right through here. You'll see what I mean when we talk about that modified Perthes test. All right, so that's all I wanted to say there. And again, these are the players of the system, peroneal. And remember, these are deep system veins. So usually blood clots start right here in the calf. You get pain in the calves. And that causes a little bit swelling. The number one sign for the development of blood clot is certainly not the Holman's test or the modified Perthes test. Those are terribly inaccurate, almost ridiculously inaccurate. But it's a little bit of swelling down here in the gaiter area, which is the ankle area. And usually if nothing's done, the casting occurs and the clot gets worse and worse and worse. Remember we talked about how it can cast all the way up. All right, but those are the members. So we have a popliteal system turns into the femoral vein. The deep femoral vein kind of branches off. Deep femoral does not extend down here. And then they all meet at this confluence here. And did they mislabel it? No, common femoral is there. Saphenous is not drawn because saphenous is a member of the superficial system. Okay, we're all good with that? Let's talk about DVT. Now, we did this in class already, so it should be easy. Thrombus, we don't really call them blood clots, right? It should be called thrombus formation, even though people call it a blood clot. Blood clotting happens outside of a blood vessel. Then that's where you get a blood clot. Or in the tunica media, you can get a blood clot for a dissecting aneurysm. But yeah, that's not the correct term. Thrombus is the correct term via the process of thrombosis. What's the cause? We gave you an extensive list of causes in class, but usually we talked about Virchow's triad. It particularly increases the chances of getting a blood clot. But the hardest one of the members of that triad to tick is the box of hypercoagulable state. So most of the people who get a blood clot, they have something called factor V Leiden mutation, which is a dysfunctional or activated protein C. They can't bind protein C, and they can't shut off the blood clotting cascade because of a mutation. Go to my lecture on that. And for lab, all you have to say is factor V Leiden. We're not going to dig into it. But factor V Leiden mutation, antiphospholipid antibody syndrome, these are by the far most common causes. If you have a blood clot, if you have thrombus, it's probably you have this. You should be tested by a hematologist. Not just the emergency department either. You need to go to a real hematologist to dig into why you got the thrombus in the PE. And there's other causes of the hypercoagulable state. Cancer, new cancer is notorious for presenting as blood clots. So that needs to be investigated. One of the legs of Virchow's triad is prolonged activity, or venous stasis, where you're in the hospital and you can't move, or you're on a 6-hour, anything over 4 hours increases the activity at altitude, right? When you're in an airplane, you're like at altitude. You're like at Vail, you're at 8,000 feet within an airplane. So prolonged inactivity can do it because the blood just pools and it can start to become mischievous. Surgery really goes back to prolonged activity, and as they cut into the damaged tissue, they're going to destroy blood vessels, and those blood vessels are going to release all kinds of things, the von Willebrand factor, all kinds of prothrombogenic molecules are released. Greatly increases. We talked about Pete Wilson, a talk show host I really used to like. Passed away from a PE's saddle embolism, got him. Brand new one, right? SARS-CoV-2, the virus that causes commonly known as the coronavirus. SARS-CoV-2, we just learned, actually, I read the research every day. I learned about 3 weeks ago. It's causing blood clots in people, and we don't know why. The New York docs just presented 5 cases in the New England Journal of Medicine where young, healthy people, 30 to 40, 5 of them died not of respiratory failure, of blood clots, massive blood clots to the brain, arterial blood clots. So this little bugger somehow is stimulating the cascade. Their D-dimer levels were way up. Their thrombin levels were way up. What the mechanism of that is, we're still trying to figure that out, but that's an interesting and horrifying story, especially for those of you with factor V Leiden mutation and antiphospholipid antibody syndrome. You have to be extremely careful of that virus. We'll hear more. Just heard it on the national news yesterday, but we'll hear more about that. Who cares about these DVTs? You have to be really careful as chiropractors and people who are evaluating, primary care docs who are evaluating sciatica, because I can tell you from personal experience, it can mimitate sciatica to the T. You can think it's a flare-up of sciatica. And it's my time away from home when I was working with a spine surgeon, there were several cases of it that they talked about. Another chiropractor had DVTs, and he thought it was sciatica. It can really be misleading, so you have to be careful with this diagnosis. If I would have known what I know now, it never got as bad as it did. But that's really the impetus of this lesson today, is to make you guys aware of how sneaky it can be, because it can imitate sciatica. And if you don't pay attention to it, and if you just take opioids to block the pain, it can cast and it could kill you. I'm lucky I'm here right now. Anyway, so of course the danger with casting and the buildup of gunk, thrombus, blood clotting in the vessel is it can break loose. You get yourself an embolism. And good thing, at least it's in the venous system. As long as you don't have a hole in your heart, it'll end up in the lungs. If it's not too big, it should pass through the heart and get stuck in the lungs. It can wreck a piece of the lung or so, which is a pulmonary embolism. much better than an arterial embolism, which can kill you really quick. Look at these death rates for treatment. So for the death rate for a pulmonary embolism, so that's a blood clot that forms in the leg, it breaks loose and travels through the heart, gets stuck in the lungs, the death rate's about 20%. That's with treatment. That's only almost a quarter of the people will die. So death rate is much higher for those who don't seek treatment, and much higher for something called a saddle embolism, which we already talked about in class. So bottom line, you got to catch this stuff really early. Of course, when the DVT travels through the heart and gets in the lungs, it's called a pulmonary embolism, or PE. The findings of DVT, and I didn't put this slide in here, about 50% of people are completely asymptomatic. So it might be impossible to catch this. But if there are signs, you better catch it. The number one sign is edema around the ankle. And I'm not talking, I had a little edema, and that should have been my clue right there. But not much. It wasn't much. So if you see edema in the calf, or especially around the ankle, kind of a dependent type edema, and it's not on the other side, and it's in the sciatic leg, they go to the hospital immediately for an ultrasound. Trouble with ultrasound, that specificity and sensitivity is not the greatest. It's better when it gets up in the thigh, in the bigger vessels. And then the other problem, it can't get up into the iliac vessels. I was super lucky because they did an MRI in me to look for other causes of sciatica. An MRI of the pelvis caught mine, for God's sakes. So it's a very, you have to be the squeaky wheel with this thing. If you have edema and they miss it, it doesn't mean it's not there. But that's all you can do is refer to the hospital and let them handle it. We'll talk about pitting edema. We've already talked about pitting edema. In the measuring tape, we've talked about that when we talked about the lower extremity exam with the pulses. Warmth, the area might be warm. Mine wasn't warm, just a tiny edema. And my leg's always a little erythemic because I have CRPS 2. So that's the thing that kind of faked everybody out with me, because I already had a condition that had a little bit of edema and warmth. But I had more than normal. But I should have stuck to my guns. And anyway, if the affected vein may or may not be tender to palpation, so sometimes they say you can feel casting, or palpable cords are nothing more than casting that go up into your calf. Modified Perthes Test and Holman's test, they might be positive. Coin flip, really ridiculous tests. I'm just teaching to you because especially Holman's test that's been around forever. And it's a ridiculous test because it misses the dangerous ones. It only tests for DVT in the calf. The dangerous ones occur in your thigh, in the really big vessels, in the femoral vein, in the deep femoral vein, even in the common femoral vein. Holman's test is not going to test that. Perthes test might catch that, but I'm a little worried that might actually cause a PE. All right, but let's look some more at thrombosis. So inspection, I think we said this before in another lab, but if they got sciatica going on in this leg and they come in like this, they got problems with their veins, don't they? They have superficial venous insufficiency. So the valves of their superficial system are shot, and they're not columnating blood, right? These veins are delicate. The valves are there to break the blood up into columns so you don't overpressurize that section. If the valves start going, then you got a double column of blood. The next valve goes, you got a triple column of blood, and it starts wrecking the vein. So that is a breeding ground for thrombus formation, especially if he gets sick, he's in bed for a long time. So you got to think, when you see something like that, you got to be really careful and make sure they don't have a blood clot. Standing will bring out, makes it a little harder when you put gravity in there, makes it harder for blood to get out of there. All right, but it indicates venous insufficiency. Again, number one sign of a DVT is deep vein thrombosis, is visible ankle edema, unilateral. If they have sciatica, great. If all of a sudden your loved one or a kid, all of a sudden they have swelling around one ankle and not the other, you got to think DVT until it's ruled out. You can do all these other tests, but you got to send them to the ER if it appears out of the blue, just to have an ultrasound. Right? You don't send them to the primary doc because it could break off into a PE and kill them by the time they get to their primary doc and he sends them for an ultrasound. Got it on that? Now, there's other signs of deep vein insufficiency which are even more worrisome. I wouldn't be as worried about that because there's not a lot of swelling around his ankle. He doesn't have any signs for deep venous insufficiency. This is more superficial venous insufficiency. Even if he did have a clot, I mean, you still would refer him to the hospital, but I wouldn't be as worried. The telangiectasia, reticular veins, not so much varicose veins, but all of these are signs of venous insufficiency. Telangiectasia and reticular veins and swelling, and especially brawny indurations, these are signs of deep venous insufficiency. The valves of the deep system are screwed up, and that increases the chances of them having a DVT. The brawny indurations or the bronzing, remember we talked about, that's a sign of they're on their feet a lot, or for whatever reason their lower extremity is under a lot of pressure. It has way too much venous blood all the time in it, and blood cells get squirted out into the interstitium and they explode and release hemosiderin, and that tattoos the skin permanently brown. Okay, a sign of chronic venous insufficiency is edema. We talked about that 3 times now. It definitely, especially if they have sciatic and pain in that leg. If this is your patient that comes in, they go out of your office, they go right to the emergency room if there's no explanation for this. Right? Maybe they just had ankle surgery, or there's other things that can cause swelling. There's no reason for this, especially if they have leg sciatica. They go to the emergency room. Everybody got that? All right, telangiectasia, if this is the sciatica leg, we talked about this as a sign that blood is hanging around too long. It's chronically having trouble getting out of the lower extremity. It could mean that the valves are damaged, and thrombosis occurs around the valves, especially damaged valves, so that you have to be really suspicious that you have to check this ankle for pitting edema very closely to make sure it's not there. If it is, they go to the hospital. If there's any swelling in this, they go to the hospital. If they say, oh, this has been like this for years, then you can, if there's no swelling, if Homan's test is negative, then at least you're safe. Your license is safe. But if there's swelling, they go to the ER. Hemosiderin stains. Talked about those before, just talked about those. Remember, we use the back of our fingers are better for testing warmth. I'm going to check down here to make sure there's no warmth in addition to swelling. Make sure it's not red in color. Sometimes the swelling's really hard. Mine was so subtle. I mean, the two docs, very prominent docs who examined me, missed it. But I knew it was there, and I didn't listen to myself. Anyway, yeah, so that's the temperature differences. You get out your tape measure, too, and measure the calves. If there's a 1/4 inch difference, it's okay. If it's a 1/2 inch difference, if it's swollen up, this is the sciatica leg. It measures 16, and this one measures 15.5. They go to the ER. That's swollen, whether you can find the swelling or not. That's got to be checked. So you got to get that tape measure out. It's a little bit more difficult up in the calf or up in the thigh to see that. And the calf is the big one. If anything, if they have really bad radiculopathy and radicular pain, this should be shrunken because the S1 and L5, those two most common nerves injured in a disc herniation, usually make the calf skinny. So it certainly shouldn't be bigger. Pitting edema. So this is how you check for that. You push. Remember the tibia is shaped kind of like a triangle, and it's got that sharp point there, that anterior border, and then there's the medial surface. I guess I should draw this. Remember that tibia is shaped kind of like that. All right, this is the one that we're doing, this one right here. Oh, I like this highlighter. So that's the anterior border. But this is where you put your fingers right here. Right, you push in here to see if you leave pits in here. And you can do that down on the malleolus down here as well, which is not shown. That's the way, and that was one of your lab tasks. You might be, well, I guess you won't. It looks like we're doing written tests again. But in boards and things, you might be asked to examine the lower extremity for pitting edema. And you push your fingers in. Don't pit over here. This is Tom, Dick, and Harry. There's tibialis anterior. And there's extensor digitorum, and there's hidden Harry in the bottom. Remember, that's Tom and Dick and Harry. Don't put your fingers over here. There's nothing to trap. You're not going to trap any swelling there. It has to be medial to the little shin bone, if you want to call it that, to the anterior tibial border, which is that top spiky thing. Right? I used to take big points off for that if you missed that. All right, and don't forget to check the lateral malleoli, medial malleoli here. I wonder if that stays. Oh, it stays. All right. Here's an obviously looks swollen around the ankles. This is just to show he's pushing his thumb in here hard and letting it go. See the pit? Pitting edema. If that's the sciatic leg, they go off to the ER. Oh, this is kind of cool. It even looks like you can see that as good as the laser pointer probably. So it's normal. Now be careful. If both legs have a little edema, it's normal for people to have, especially if you're on your feet all day long, it's normal to have a little bit of swelling in there, especially if you've had a salty lunch. Increases the fluid in your blood a little bit. So you don't want to freak out about it. But if it's unilateral swelling is what you worry about. Okay, but it's abnormal to have unilateral pitting edema. Said that like 4 times now. Unilateral versus bilateral. So unilateral pitting edema could be the DVT. That's what we're worried about. Or it could be in a tumor. Maybe there's a tumor in the popliteal fossa. I just saw a paper on that rare arterial tumor compressing the venous side and causing swelling. But maybe it's some beaver dam in the deep system, and that's what unilateral edema usually is. If it's bilateral edema, well, and incompetent valves too. Maybe you've had an old DVT and the valves are shot, so it's hard to get blood out of your lower extremity. So there's always extra venous blood there because of that. Bilateral pitting edema. Now we talked a ton about that. There's probably the first thing that comes to mind is cirrhosis of the liver from hepatitis, from drinking, and there's alcoholic fatty liver disease. There's a bunch of things that cause cirrhosis of the liver, but they all cause a beaver dam, right? And we know that if you get a beaver dam there, everything upstream will be blocked, and upstream would be down in your lower extremities. So beaver dam in the heart, left ventricular failure of the heart could cause it. COPD could cause a beaver dam. Right heart failure, we talked all about this in class. Maybe it's an embolism, or maybe it's thrombus formation in the inferior vena cava. Would that cause bilateral or unilateral? Bilateral, right? And that pipe would split off into the common iliac vessels, veins, so it would cause bilateral. All right, we looked at that again. There's just some more examples. Patient with cirrhosis, noticed pitting edema here. And again, you could probably do this at the end of the day if you've been on your feet all day and had a salty lunch. But not like this. This is, you can't even see the metatarsals, or you can't see any of the arteries, normal venous circulation here. That's way swollen on both. That's a patient who had cirrhosis of the liver, failing liver. What's the other whammy from cirrhosis? How else can cirrhosis cause generalized swelling? Beaver dam, we said that, but that's going to only occur in the lower extremities. How can it call puffy hands and a puffy face? General swelling. Right? It makes albumin. Albumin's super important at sucking water back out of the interstitium. So people swell. Good. Can an arterial pulse predict DVT? Typically, no. Magee, the Magee board book is terrible on this. It's just really that book needs to be overhauled. I don't like that book. But it is a board book, so I had to add some of this stuff in there. Typically, no, because the DVT is in the venous side. You're still going to be pumping blood in through the arteries. So you'll have a popliteal pulse will be there. You'll have a dorsalis pedis. You'll have a posterior tibial pulse. Unless the only time that you won't have it is if the swelling is so bad that it's started to back up into the arterial system, right? Because the upstream backup goes into the smaller circulation of the veins, the arterial or venules, but it can cross into the arteries and get into cause swelling that way. And if the limb gets so swollen that you can't physically palpate the dorsalis pedis or posterior tibial, that's the reason you can't find it, because it's filled with swelling. But if there's no swelling, that has no bearing on whether or not the patient has a DVT or not. So Magee needs to change that. Not the evidence-based, not the MCGEE. I really like that book. It's the other one, the MAGEE. That Magee book needs to get with it. Test for patency. Okay, now let's come to our testing section. I don't know if I'm going to. You guys already know how to do Holman's. Modified Perthes is more of a demo. I'm positive I'm not positive, but from what I've heard, no one's asked that on boards yet. But it is the test. It is the other test, so we will go over it. So who do you do these tests? Do you do these tests on every patient? No, you don't do these tests on every patient. You do these on the sciatica patients. Or if you see some swelling down there in the gaiter area, then you can do the tests if you want. Really, if you see swelling, again, fifth time, if you see swelling around the gaiter area, around the ankle, and someone with sciatica, they go to the ER. Simple as that. This other stuff is more for board purposes, and maybe if we're out in the woods or out in Alaska somewhere, you have to go. Your scope is bigger, so it's just to know more. But for your purposes, off they go to the ER. So any patient, these tests are done on any patient with swelling, a calf that's a half inch or more bigger on the same side, if they have erythema, if they have warmth, I don't know if I've added that, increased temperature change. If they have hemosiderin stains and they have sciatica, then you better do the tests. If they have telangiectasia, any of these signs of deep venous insufficiency. Of course, if there's ulcerations, deep venous insufficiency signs. Again, tests are horrible sensitivity and specificity. Sixth time, send them to the ER if they're swelling. So a duplex ultrasound can be ordered. Personally, I wouldn't do either of these tests out of fear of jarring loose a thrombus and causing an embolism. In this litigious society, especially in our state, I would just send them to the ER. But you should know how to do them because we got to test you on something. Modified Perthes. So here's the story. Checks for patency of this is not a test for this. I can see the test question. Modified Perthes test tests the patency is a test for the patency of the superficial venous system. No, deep venous system, right? It's to make sure the deep veins aren't clogged up with gunk, thrombus. So step one, patient lies on a table, supposed to lie there for 5 minutes, and there's like 10 interpretations of this test, right? So I'm doing the most evidence-based one from the best resource. So they lay on the table to let any excess blood easily get out of the lower extremities because there's no gravity. Venous blood will move out of the extremities in 5 minutes. Then you place a tourniquet. We've been using those let's see what color, the red colored, the second, I think the orange ones are really the lightest exercise band. Those break, but the next level up, I think the red color is what we use. And you just put it around their proximal thigh like this. This might even be a hair too tight. The trick is you want to compress the saphenous vein and its accessory veins, but you don't want it so tight to compress the deep system, right? Because then the blood can't get out anyway. And the whole test is we're testing, as I showed you, we're testing to see if the deep system is patent, is working or not. So if you put it on too tightly, you're going to basically put a tourniquet on the patient's leg, and the test is not going to work. Oh, it'll be positive, but it's positive not because of a DVT, because you put it on too tight. So that's the key there. So just want to include the superficial system. And then after you put it on, you have them get up and walk around the room for 5 minutes and don't tell them anything. So you're looking for pain, claudication pain. If they have, okay, here's their cartoon of their deep system. So that if they have a beaver dam here and the blood is trying to be pumped out and it hits the beaver dam, it can't go anywhere. So it goes through the superficial system and it tries to get out through that system, but it can't get out there either because you just blocked it off here. So where does the blood go? You got arterial blood coming in. It doesn't go anywhere. It expands and blows out the veins, the saphenous veins, so much. They have nociceptors on the outside of those things, and they start to hurt. And that's positive. You may get claudication pain. But claudication doesn't mean the pain's in your calf. It could be anywhere in the leg. So that's a positive. So they walk for 5 minutes. Some authors allow, maybe they can't walk, they can do calf raises. If they can't walk, they probably can't do calf raises either. So that's why, this test is not the greatest in the world. But it's positive if they have pain during the walking. Also, this guy was lucky because there is, let's see, how do I, oops. Bear with me a sec. There's the eraser. Okay. So, you see anything unusual in his leg while I'm getting back to my highlighter here? Look, he's got a varicose vein right there. And you can tell he's got venous insufficiency, doesn't he? Look at the hemosiderin stains. So he fights it. But you can also watch this right there. If you can't get blood out of the deep system and blood is forced into the superficial system, that's the superficial system varicosity there. That's the short saphenous vein or lesser saphenous vein. That thing's going to swell up like crazy, probably within a couple minutes. So the test is also positive if you see that swelling, if that increases in size. Okay. And yep, so everything we said. So superficial varicosity will bulge like crazy, probably within a couple minutes. I kind of like this marker. I think it actually stays on your slides too if you want it to. Why do we get the pain? Because everything I said. The blood's rerouted and it increases pressure and it hurts. That's why it's positive. Already said that. We already talked about that system. I don't need to talk about that. What does a positive mean? Well, everything I said. If it can't get out the deep system, it blows the valves. The one-way valves of the perforator system are blown open. Right? That's how it tries to go out through the superficial system, but you block that, so it can't do that as well. What action should you take? Guess what? Refer to the emergency department. I am nervous about this test, though, because I don't like pressurizing the deep system. I'm worried that it might break loose a piece of thrombus and cause a PE. So I don't think. I scoured the research. I couldn't find any contraindications to this test, but there's just not a whole lot on it anyway. when you send them to the ER, this is the test they do. This is not how they do the test. I've had a bunch of these. These are always done supine because you're pooling blood down here. So these are done supine, and they have to search for blood clots. And you're at the mercy of the technician's skill. I've had these done at Stanford with some guy who's been doing it 30 years, and he said even at his level, he has trouble seeing, especially if there's doubles. Remember how the veins can be doubled? He has trouble really finding blood clots down in the lower extremities. So just because it's negative, don't 100% believe it's negative. Homan sign, I'll whip through this. You guys already know this. The positive and negative predictive values, in other words, the false positive rate and the false negative rate are terrible. Sensitivity and specificity are terrible. The sensitivity, so that's a false negative rate, is only 30%. I mean, this is a worthless test, yet they still, I mean, it's classic. It's still on medical boards. It's still on all the boards use it. But yeah, and then as I said before, the silly thing about it is the ones that you're really worried about are if they occur up in the popliteal fossa and the deep femoral and regular femoral veins. Those are the ones that'll kill you, and it doesn't test for those at all. So don't let it shouldn't give people a sense of false security. Here's from Magee. I'll show you how the vascular experts recommend doing it. Now, you can't do this on someone with sciatica, right? What's it going to do? That's a Braggart's test. It could hurt their leg. It could stir up their sciatica. And so you might get a false positive from that. But this is the way Magee, that's the board book, says to do it. Patient is supine, and you do a dorsiflexion. And it's as simple as that. If they have pain in the calf, ouch, my calf hurts, the test is positive. Now, here's where Magee starts to get a little cuckoo here. Well, this one, I can buy this one. So you palpate the calf to see if there's cords or tender cords. That is another positive sign. That's about 50% accurate. But this is where he goes, this needs to be revised here. He says that if you see pallor, that's whiteness, right? That's an arterial occlusion. That has nothing to do with a venous occlusion. So that's wrong. It's erythema. And the swelling is definitely correct. If you see swelling, that makes the diagnosis. But pallor, no, it should be erythema. And then he goes on to say if there's a loss of the dorsalis pedis pulse. That's not going to happen unless there's severe swelling. So don't think that I had a perfectly normal dorsalis pedis pulse, yet I was casted from my calf all the way up into my iliac vessels. And I had a normal pulse. So don't think that is an indication at all. I didn't have that much swelling. Okay, and that's a sign of, I think he called it thrombophlebitis, that old word I told you that we're trying to get away from, but he called it thrombophlebitis. Well, what about thrombophlebitis or the other ones? Yeah, deep vein thrombosis is the preferred term. By authors actually are starting to make rants about that. So terrible, Magee. Clean that up. The vascular specialists recommend doing Homans like this. You flex the knee to 90 degrees and then perform the test. That takes away any tight calves. Some people have tight calves. If you have sciatic in the leg, that takes away the false positive a Braggart's test may give you. I mean, that makes sense. But that's not, on medical boards, you have to check with whatever your source is. But on chiropractic boards, this is not the way to do it. If you're really doing it for real, this is the way to do it. Okay, what's a positive? It's pain in the calf or behind the knee. One differential diagnosis, you better put your fingers back there, Baker's cyst. It can also be painful. If it's tangled up in the gastrocnemius at all, or you might palpate a Baker's cyst back there. It's probably not tangled up in the gastroc, it's too low. But they can be painful as well. All right, let's get to Buerger's test. So do we know a disease? Yeah, we know Buerger's disease. So it kind of goes with that. So it's a test for peripheral artery disease, mainly PAD, or Buerger's disease. Really tests for those two, but mainly PAD is much more common than Buerger's disease, at least in our country. This test is many different ways. Again, the authors are all over the place. So we're trying to keep Magee. This is the evidence-based Magee book that I like, but that's not a board book. So I did inject the board book Magee in here just to show you what they say. It's not described completely in Bates or Seidel or Jarvis. The Spitzel describes it really nicely, best description of it, but that's not. I don't know if medical students are using that one or not, but that's a good book. And then Magee's a really good book. I recommend that should be a Board of Chiropractic Examiner book. They do a good job of explaining it. In fact, this is from the evidence-based Magee book. Look at how I really like this guy. It's referenced where this stuff comes from. And he explains all the different kind of views of how to do Buerger's test. So you can read them. I'm not going to test you on that slide, but I really like this author. It's a great book. I don't know why it's not a Board of Chiropractic Examiner book. Here's how we're going to do it. So patient is supine again. So think of this now. Do I have a picture? So let's try to draw here. So this is, oh gosh, here's one of my famous drawings. There's a kneecap. There's a foot, calf, thigh. So if we lift this up, I have to draw it again, don't I? Kneecap, shin, foot, heel, calf. If we lift this up to 45 degrees or 60 degrees, we're lifting it up. Let's back up. So here's, let's say, one blood vessel. Without gravity, this patient is okay. His foot looks okay. But if you lift him up, I don't know how to make that any smaller, but if you lift him up and he's got narrowing, a beaver dam in here, the gravity is going to be enough to stop the flow of blood, right? And what's going to happen to the foot if you don't have an arterial flow of blood to it? No, it's not going to turn red, right? That's a venous backup. That's a beaver dam on the venous side. It's going to turn white. It's going to turn palloric in color, right? So that's what we're looking for. We're testing the patency of the arterial supply to the foot. That's what this test is. If the pipes are clogged and you put a force against those pipes, such as gravity, and a foot turns white, that just tells us these pipes are really, really clogged. So that's kind of where we're going with this test. So 60-60, so you're going to raise the legs 60 degrees. You can do one at a time or you can do two at a time. If I can get my wife to do this, I'll definitely do it one at a time because of my back. So if you have back problems, it's better to do one at a time because lifting both extremities can be fairly heavy. Probably not to young students, but older practitioners out there. Some authors say lift them to 90 degrees. Magee says lift them to 45 degrees for 3 minutes. The more evidence-based books say all you need to do is 60 seconds. And I think that's the way to go. But there's a lot of variety in this stuff. So we're going to go 60 and 60 to make it easier to remember. So you're going to lift the leg up, or if you can are strong enough to lift both of them up at the same time, that's better because you can compare side to side. Lift them up and watch the bottom of the foot for skin color change. What's a positive finding? This is positive. This is normal color of a foot after 60 seconds. Maybe even a little too red. I don't think this is probably taken about 5 seconds after doing it. If you wait for 60 seconds, this redness will be, but this one will be even whiter. This is no good. The pipes are messed up. The arterial pipes are messed up in this patient, and they can't supply blood to the foot. If you left him here for 5 minutes, it'd probably start turning blue, becoming cyanotic. Okay, Magee calls it blanching instead of pallor. Bates and Seidel call it palloric. So watch out for that. They're both board books. So blanching is the same as blanching means to make it white. So they're both the same. So watch out for that AKA. And it suggests PAD. What causes this? PAD. Magee says use anything more than poor arterial blood circulation. At least they got that right. So that's what Magee says. But the other books, but Seidel and Bates say peripheral arterial disease. But Buerger's disease, not as prevalent in this country, but other countries like India, it's much more prevalent. All right, so the pipes are clogged. Got it? All right, now there's a step 2 to Buerger's. When we were testing for real, I would have, I might say, I want you to do part 2 of Buerger's. Do the confirmation test for Buerger's. We'll assume part 1 was positive. For part 2, the patients, you just did part 1, they're still supine on the table. You just have the patient sit up and dangle the legs over the table. They're sitting on an exam table for this test. And you watch the fill, you watch to see how long the blood flows back into the lower extremities. In other words, you put the patient's lower extremities in a position of dependence. Okay? What's normal? Within 15 seconds, the feet should come back to their normal color. If the room is warm, the feet are usually a rosy red color or a pinkish red color. So they're going to be a little white because you just drained some of the blood out of them. Even in a normal person, they'll be a little more white. They won't be pink-red anymore. But if you swing them in a position of dependence with gravity, they'll turn back to their pink quickly, probably within 5 seconds. But within 15 seconds is the rule here we're going with. Okay. Usually you can also watch the small veins. Everybody can see veins in your feet, right? That superficial venous arch. When you lift your feet up for 60 seconds, it often disappears. When you swing it back down, it should pop up also within. So you can watch for veins and that color to change normally within 15 seconds. A positive finding is simple. If it fails to return within 15 seconds, you got yourself a little bit of occlusion going on. All right. In fact, it's a moderate tissue ischemia. And I'll show you a chart here in a second, but that's all for you. It should within 15 seconds. If it doesn't, we're worried about the arterial occlusion. Then what test do you order? Ankle brachial index. You can check the flow of arterial blood through ankle brachial index. All right. If it's 20 to 40 seconds, it's more delayed. They say it's a moderate to severe tissue ischemia. That means the pipes are clogged, moderate to severe. If it's more than 40 seconds, there's a phenomenon that occurs. And so when you had someone with venous insufficiency, let's go back to this picture. So if the tissue is sensing that it's becoming ischemic, what did the endothelial cells do? They release tons of nitric oxide and other vasodilators. Those things, they kind of get pooled up down here. They can't because of the force of gravity, and the blood is just not flowing. It might even be going a little backwards. These mediators pool up, right? So now we got a pool of nitric oxide and other vasodilators. What's going to happen when you swing this foot so it's pointing down like that? They're going to come, there's the artery again. They're going to come flying down, and they're going to over vasodilate all the blood vessels, and your foot is going to turn red as this color is here. Your foot's going to turn. That's got a classic old school board word called dusky red. The foot's going to turn dusky red, or rhubarb. Okay, so dusky red or rubor in color. And that's another one. Magee says if it takes greater than 60 seconds, that doesn't jive with any of the vascular specialists in any of the papers that I've read on this. So that needs to be cut way down, because 40 seconds can be bad enough for it to become red. So, but nevertheless, he's a board book, so keep that in mind. That's I won't say anymore. I've probably beat that book up enough. There are some good stuff in that book too, but this is not one of them. What's the mechanism? That's everything I just explained to you about the vasodilators being overproduced, and then when you add gravity, like this leg, right? That's a dusky red. It was white a few minutes ago, 40 seconds ago, a minute ago when it was up, and you swung it down, and in 40 seconds, boom. That indicates, did I say what it indicates? It indicates that is severe. Did I put it in here? It's called critical limb ischemia. Severe ischemia, yeah. Oh, there it is. Just didn't highlight it. So critical limb ischemia, that's the end stage of PAD. And honestly, if dusky red phenomenon occurs, I'm going to expect to see ulcers and other problems, and that is true in this guy. So I'm surprised his toes aren't even a little gangrenous. All right, so that is the lab, and we'll see if I can do a demo. If not, I think it's pretty easy to do. Okay, see you in the next video.